First and foremost, just great to be back live in a room. I think that we've all been on screen a lot, so this is wonderful to be in a room with people and sitting next to people. So this panel today, with the implementation of the Patient Protection and Affordable Care Act, we're really coming back with a really great group to check ourselves as healthcare providers, as administrators, executives in the ecosystem, and just ask ourselves where we are now. Where do we stand? How has innovation and technology changed things, moved things forward? Obviously, in the last 18 months, there's been a force of adoption that so many of us have waited to see for such a long time. But I want to get right to it with this great team. So our panelists are leaders, entrepreneurs, change agents who've been around for a long time. I've sat on both sides of the table with so many of them, negotiating, challenging, getting pushed back on, and vice versa. So it's a great crew. And with that, I'll just kick off and ask each of them to introduce themselves, their organization, and their background, and describe, what they're up to personally, professionally, what their organizations are doing as far as changing the face of healthcare delivery and leveraging innovation and technology. So why don't we just kick off with Kevin.
Thanks, Lenny. Nice to be here with you all today. Nice to be in person. I'm Kevin Kumbler. I'm the president of Burnout Health. We are working to reverse type 2 diabetes in 100 million people by 2025. And I've spent the last 10 years in health tech, mostly working on access issues at ZocDoc for 6 or 7 years, creating broad access to healthcare. The last couple of years at Quartet Health, working on access to behavioral healthcare, and now at Burda, trying to take the best clinical program for type 2 diabetes to people all over the country and eventually all over the world. I'll pass it on to my next panelist.
Good morning, everyone. I'm Jean-Luc Neptune. I am a physician and entrepreneur based here in New York City, and I am the CEO and co-founder of Central Modern Recovery. I trained within the Columbia system here in New York, so I was a Columbia undergrad, went to PNS, and did a residency at CPMC, or CUMC now. Central Modern Recovery is an addiction recovery management service. And what we do is we work with families and individuals who are dealing with substance use disorders to achieve long-term recovery. So we provide a spectrum of outpatient resources to families. So we do education, navigation, we help families with interventions. And then individuals who are dealing with substance use disorders, we help them with case management, medication-assisted treatment, as well as long-term recovery coaching. And the stats are very interesting in this space. There are 20 million people who have substance use disorders, but only about 10% of that population will get specialty care in 1 year, so there's a big unmet need in this space. And there is lots of evidence, although very few people get specialty care, there's lots of evidence that a well-structured, well-resourced recovery program with a well-structured resource recovery program, people can achieve 90% 5-year sobriety rate. So I think there's a lot to be done in the addiction space, and exciting to be in this space. People often ask me, am I in recovery myself? I am not, but my long-term business partner is, and that's how I got into this space. So we have a great team and doing interesting work. Thank you for being here.
Great. Well, good morning, everyone, and great to be with you, Lenny. Thanks for the invitation and all your coaching and pushback over the years as well. So I'm Graham Gardner. I serve as the founder and CEO of Kairos. I'm a cardiologist by training, but I've been working at the intersection of healthcare technology for the last 15 years or so. Started Kairos about 10 years ago to help organizations better match and route patients to the right provider or destination for care. So think of us a little bit like the old Sabre system that travel agencies use, or kind of an enterprise, Travelocity, or Kayak. So what we do is basically create a digital inventory of who does what, where, when across the network, and then power schedulers, whether it's an access center agent, a patient self-scheduling, or referring provider, to all be able to navigate and find the right match for them within the organization. We work today with about 300,000 providers across 700 hospitals. We also recently acquired a company called HealthSpark that added about 80 million members and about 50 different health plans there, and beginning to kind of help bridge also that navigation now across payers and providers as well. So look forward to talking more.
Hi, everybody. I'm Neil Shah. What I should say is, I'm a skinny Indian kid from New Jersey, so I went to medical school. And when I was a medical student, I called Graham, and I was like, how do I be you? And here I am. I should probably just leave it there. But right now, I'm the Chief Medical Officer of Maven Clinic. We're the largest virtual provider for women and families. And every journey to parenthood is personal and unique, and punctuated by moments of deep vulnerability. And the through line in my career is just recognizing that maternal health is a bellwether for societal health in general, and if moms are unwell, society is unwell, and that's why every form of injustice shows up in the well-being of moms, whether it's racial injustice or gender inequity or geographic inequity or generational inequity. And was part of a team as a professor over the last 10 years that pointed out that an American today is 50% more likely to die in childbirth than her own mom, 3 to 4 times more likely to die if she's black, and had spent a lot of my career evangelizing what we should be doing to fix it, and met like a back-end engineer in San Francisco who knew that the C-section rates were too high. And I thought that was cool, but that shouldn't be my epitaph. Like, what are we going to do about that? And right now is just a really good time to be building new ways of delivering care for people. So I'm excited to, share some thoughts on how we're thinking about doing that.
Great. Rob?
Good morning, everybody. My name's Rob Kral. I can introduce myself as I was a skinny kid from Canada. is the operative word. I'm the Vice President and General Manager of the Connected Health Group at Zimmer Biomet. For those of you who don't know Zimmer Biomet, we are the world's largest pure-play orthopedic device manufacturer, primarily known for our large joint portfolio, knee and hip implants, but increasingly known for our technical innovation around robotics, digital care management tools, smart implants, and my background, a little bit about me, I've spent my entire career in healthcare. The first 10 years as an RN in the pediatric ICU. My last clinical job, I managed the pediatric ICU and interventional cardiology departments at UCSF. And then 10 years in med device in various sales and sales leadership roles. And then the last 10 plus years as an innovator and an entrepreneur. I started a device company, sold that company, invested in a med tech startup, became their chief revenue officer, and we sold that company to Zimmer Biomet 5 years ago. So happy to be here. Thanks everyone for coming.
Great, thank you. So yeah, we wanted to bring this group in to get the other side of the table, a different perspective, different point of view about this conversation. With that said, with question one, you hear innovation, you hear technology. It's a pretty played out word. So we're going to level set today. When we talk about technology and innovation, it means so many different things. Big pet peeve of mine. I mean, look, for a host of reasons, it's talked about as process improvement in some organizations. For others, it's just a press release mill of tons of press releases about anything that looks cool or that looks like innovation. No judgment, just saying. For others, it's about scaling new things, and for many others, even in New York, it's innovation's a venture investing group. None of these are wrong or right, but I want to first hear anybody who wants to jump in about how you define innovation and technology, or even just innovation.
I think the way that we define innovation, when you think of Zimmer Biomet, I think you think of an orthopedic device manufacturer. That's the first thing that comes to mind. And we do that, right? We do manufacture orthopedic implants for sure. And our innovation largely was around the implant, around how the materials in the implant, the instruments used in the case. But that's changing as Zimmer Biomet and companies like us make this transition from med device to med tech. Things are changing for us. We'll continue to innovate around the implant for sure. Just recently, we announced FDA, along with our partners, Canary Medical, FDA approval of the world's first smart implant. So that's an implant that has sensors built into the tibial extension. Surgeons now have this ability to collect high-fidelity data directly from the implant. This is a pretty watershed moment in orthopedics, and we're on the forefront of that. But our innovation is in a larger context of not just the procedure. We've always sort of focused on the 20, 30 minutes around that procedure, but we're innovating beyond that, around the entire episode of care, bringing value to health systems and our partner providers. That's through digital engagement tools, digital care management tools that add this extra value around the entire episode and this ability to push content to patients to help them prepare for and recover from their surgical procedure. And we innovate around robotics. We have a platform called ROSA, which now has 3 applications. Surgeons can do total knees, partial knees, and direct anterior hip with that one platform. But most importantly, they can start to data collect during the procedure. So the robot has this ability to collect the data during the procedure. and connecting that data to the care management system, which is really a unique thing. And we are very much a mission-driven company. Our mission is to alleviate pain and improve the quality of life for people around the world. So when we think of innovation, we think about innovating in that context. How do we innovate to alleviate pain and improve the quality of life for people around the world?
Thanks, Rob. Anyone else?
Yeah, I run a company that's growing quickly, that is orders of magnitude smaller than, Zimmer. Every day we're innovating, right? And to me, innovation is really any change that I can make in any particular day that allows me to do something with fewer steps, at lower costs, more quickly. And, I think not everybody is experienced with the entrepreneurial journey, but when you have a company, your company is literally making dozens of changes per day, right? I mean, I have a list at the end of the day of all the changes that I made, and it's a very evolutionary process. So I think about, innovation as any kind of product change I can make, business model change, marketing change, servicing change, reducing the number of steps, reallocating resources that allows me to provide our service at a lower cost, more quickly, or higher quality.
Do we appreciate that on the provider side? Do we know that yet?
I don't think so. I mean, I think a lot of providers, and Lenny and I was an entrepreneur in residence at HSS for 3 years working with Lenny. So I think that, you have large providers who work at large organizations who don't really understand like how rapidly evolutionary the process is for startups, and often will view startups as if they are also large organizations. So I think, if you're a large organization, you have 10,000 people working there, you have a fundamentally different DNA, you have a fundamentally different metabolism, right? It's comparing a geriatric patient to a pediatric patient. And there are very, very different processes going on. And I think that was always one of the challenges for any large organization when they're trying to work with entrepreneurs, is they just fundamentally misunderstand what's going on at a rapidly growing company that doesn't have infinite resources, that is being pulled in so many different directions. So I think that's a very important thing to think about if you're a large organization trying to work with a more entrepreneurial, rapidly growing startup.
Yeah, but I think what you're also getting at, though, is where newness meets healthcare. And I'll probably declare myself early on as the crotchety old guy here as well. But I think one of the words you used was value. And I think one of the words that can be missing sometimes from pure tech is this actually useful? And is this valuable? I don't like the word disrupt. I don't think we should be disrupting healthcare. I think we should be bending healthcare, finding ways of adding value. And I think, you can't be directional about whether someone has cancer or not. This has to, you can't do A/B testing and just lose lives. And so I think this is the real conversation. This is why we as an industry are really struggling with how do you bring some of the best and brightest ideas from travel, from finance, but actually put that into someone's life that you're caring for as well. And this is the work we do every day.
And by the way, I greatly emphasize or second what Graham had to say there. I think you have to think about innovation differently in healthcare than in any other industry. And I think part of the problem that we've had is people are trying to apply models that have been used to disrupt media, disrupt travel, disrupt a bunch of other industries that don't really work so well in healthcare because, again, we have a do no harm culture. People don't realize like that's, we take an oath, 3 of us are doctors here. We take an oath here to do no harm and to do the right thing. And, fake it till you make it does not work in health.
Yeah, it's not everything's a 2-week sprint.
Right.
Right. It's not all like fail fast.
Not everything's a sprint.
Yeah, no.
When people at the hospital are expressing caution and expressing concern about making changes, they're not doing it to be difficult. They're not doing it to be dumb. They're doing it because they've taken an oath, either as an individual or as an organization, to do the right thing and to help people to achieve the best health they can.
That's true, but I'd also argue that part of our job is to create that friction in the industry. So our definition of innovation internally is imagining a different future and then removing obstacles to get there. And certainly we try to do that at ZocDoc, imagining accessing care being as easy, accessing the right care for you being as easy as finding the next show that's right for you on Netflix, which most of us probably got too used to over the last 18 months, but it was very, very easy. And I know Graham knows this problem well. The average patient, the average person in America doesn't know what rheumatology is and definitely doesn't know the second letters in H. So for them to be able to navigate the existing clinical systems to find the care they need is very, very difficult. And we're finding the same thing is true at Virta. The typical diabetes treatment in America has been diabetes management. This is a one-way road, and we're going to try to slow you down on that road. And we're imagining a future where diabetes is fully reversible. And our founder had been working on that for 5 years. And only 4 weeks ago, the American Diabetes Association and an international group of panelists published a consensus paper with a definition of diabetes remission, agreeing that it's possible. So we think you have to be pushing at the edges and creating that friction so that you can bring people along in that positive future.
I really like that idea, and I think what I can add to this conversation as being someone who's relatively new to industry is that I mean, like, I've been in my seat for like 6 weeks, but about 2 weeks in, I went to Health Evolution. You know, there's like entrepreneurs and investors everywhere, and I think one of the most striking things for me was coming out of academia is that the best scientists and the best entrepreneurs are actually the same person. I think that innovation is a discipline, and you know, I'm also like very struck by this notion of removing friction. I think that's like a great frame, because fundamentally, at the end of the day, so much of innovation in medicine and healthcare over the last century, it's been about dividing systems into smaller and smaller parts. Like it was, you know, like trying to figure out like every molecule that makes us up. And now the big challenge is figuring out how to put it all back together again in ways that make sense for normal people.
You know, what you're hearing is just a really strong appetite of you just keep coming, right? And we joked around outside that this was a survivors group that has made it through, you know, Death Valley of innovation and entrepreneurship, especially here in the Northeast, but also globally. What keeps you coming, right? I mean, you know, Kevin, when we met, I heard that ZocDoc brought a new president in because we were absolutely horrible to you guys, and vice versa, you guys were too. Yeah. And I was supposed to sit across the table from you one day and opted out, and another executive I put in there for some fireworks and popcorn, and you almost walked out of that room, right?
Yeah, that was fun.
Yeah, it was fun. And you kept coming, and we worked it out. And, you know, every single one of you, I mean, we worked it out. What keeps you coming? All of you. What makes that go? Kevin, what made you come back that next day or sit back down in that boardroom?
Yeah, maybe 2 war stories I'll share.
Yeah, sure.
Mine that are hopefully entertaining. The first was just around the corner from here at NYP, where Daniel Barchi looked at us and said, "You've been coming for 3 years, and we've told you no for 3 years. Why do you keep coming back?" And I looked at him and I said, "We're irrational optimists by nature. You have to be an irrational optimist to be working in a company like ours. All of these companies should have failed from day one. Most entrepreneurs do. But the ones that succeed are because they are rationally optimistic about pushing towards that positive future." And the meeting that Lenny's referring to is at Mount Sinai, where they brought in somebody basically to vendor us.
That was me. I brought them in.
There's nothing
That was my fault.
more depressing as an entrepreneur than being treated as a quote-unquote vendor, because that implies that you're providing a commodity that's readily available, and you're going to get beat down to the lowest possible price or the worst possible terms. And there's nothing that excites an entrepreneur more than a healthcare organization looking for a real partnership. But that was not the tack that was taken that day, and I was told in no uncertain terms that most of their quote-unquote vendors come into the room and put their big boy pants on first. And that's when I turned to my counterpart and said, "Do I need to remove my team from the room and we need to go home?" And fortunately, that person jumped in and helped us.
Awesome. Good old days. I've grown a lot since then, and so has Kevin. Graham, same thing, right? We met. We've challenged each other. What kept you coming?
I think all of us that start companies and continue to do them in healthcare are driven by a vision of what we think the future can look like. And we may get into this a little bit later, but Kairos reflects the worldview I was raised with, that we are all different, we're all beautiful in our own way, we all have our relative strengths and weaknesses, and that if you could find a way of matching patient and provider together, that a lot of good care would come from that. And I just believe that to the core of my identity, and people can say no to me, but I think that's where healthcare is going. Now, naively, when I raised our Series A, I thought it was going to be 3 years, $5 million, and we would solve the world's problems. I now realize these things are very long journeys. One of the things that drove some of our more recent activity, actually, and the ability to combine health system and health payer, though, is that I do think sometimes we do things in healthcare when we're ultimately compelled to do them. I don't think many people here enjoy using Epic and other EMRs, right? But you have to. You cannot take care of a patient. You can't perform your job unless you're using some of these underlying technologies. And so we think about that of hey, even when people do think there's a right thing to do, how do you align all the stakeholders by making it the only thing that you can do as well? And I think that ultimately has become part of how you drive innovation into organizations.
Absolutely. And a comment that I would make based on something that Kevin said. I mean, I think the issue that we have in healthcare, and I say this often to friends, and I like to say inflammatory things at panels, is just healthcare sucks, in the sense of the experience that you'll have. There's nowhere you'll go in our American economy where you will pay more for a service that provides lower quality, where there are as many errors as you do in healthcare. And, it's people suffer adverse consequences because our healthcare system does not operate efficiently as other industries do. And I'll tell you, having trained at a traditional academic medical center here in New York, there's a lot of programming that you take in and take on when you go through your training about what is right, what is the proper way of doing things if you're providing a service to a patient, let's say. But a lot of it is wrong, and a lot of it is actually not influenced by, let's say, modern management techniques or modern application of technology. Because the truth is, a lot of the people who are training you as you come up are totally clueless, right? They've never lived a minute outside of the healthcare system. So what happens is they just keep doing the wrong things that they were trained to do 20 years ago. So I think the interesting opportunity, and I think Kevin hits the nail on the head, is looking at every step in this process and asking ourselves, what do we really need to do here? What piece of information do we need to capture? What service do we need to deliver? And I'll give you one very specific example. In a prior life with my business partner, we had a sports medicine clinic. And I was trying to figure out, how do I make this check-in process for our clinic more efficient? And I remember engaging in literally a 2-hour debate with another doctor about whether we had to collect somebody's driver's license to deliver them a healthcare service. And literally 2 hours of yelling at each other of why are we collecting the person's driver's license? And at the end of the day, I won that argument, and I said, for the most part, in 99.9% of cases, people are not going to defraud us by using somebody else's driver's license. They're coming back here 10 times for physical therapy. We'll figure it out eventually. So let's cut that step out. So I think, a big part of what we have to do in healthcare is for people like me who are heavily programmed to sort of lose some of that programming and figure out, are there more modern ways to deliver a healthcare experience that makes people's lives better, makes them more willing to come to the doctor and get the care that they need, and, again, achieve better health.
Yeah, and I'd just add to that, right, that I think that what brings me back, brings us back negotiating with HSS and Lenny, is really, and I think everybody on the panel, you become sort of a zealot to the mission, right? You're so committed, you so believe in what you're doing. I've had, some really, really good fortune in my career to have some really incredible whys, right? Great missions. One early on was around congenital heart disease in children. Worked at a couple of different peds ICUs, and what I understood was, when I went to UCSF, is proximity to incredible surgeons, incredible care meant the difference between a poor outcome and a great outcome. And that's not necessarily fair, right? That the access to that information was not fair. So that sort of shaped me in my career and my mission. And I think now at Zimmer Biomet, what we're doing, what we're trying to do, right, is we really believe in the mission around data collection to unlock insight to improve outcomes. That there is this stubborn statistic in total knee replacement that 20 to 25% of all patients that get their knee replaced in the U.S. are dissatisfied with the outcome. It's an elective procedure. I think we can do better than that, and I think the data will set us free, that we'll eventually get better at this, and we can help.
Thanks, Rob. When I listen to all this and I think about evidence-based practice, data, information, you've pulled the veil back from the OBGYN. You've been a clinician like a few others here. You've written the research, you've published, you've been out there as a thought leader, and you're on the other side of that now, leveraging technology to do it. You went through that transition. What pushed you forward with that? What made you maybe not believe you couldn't do it from within and you needed to do it from the outside in?
Well, I think part of relentlessness, I think where it starts is just being a deeply curious person. Like when I was a medical student, I did OBGYN first to get it over with, because as a dude in my mid-20s, it was obviously never what I was going to do. And then I met people that were giving birth, and I was like, I can't believe, like, I had no idea what it's like to have a uterus, and I've just been following that, ever since. And then, I trained at the Brigham Women's Hospital, the Brigham, and my startle reflex was to do a C-section, right? Because it's like a high acuity place. And then Atul Gawande gave me the job of trying to fix childbirth in America. And turns out, we do a lot of C-sections that are dumb. And I was like, well, I'm always right when I do a C-section, because if the baby comes out perfectly, it was a good thing I did a C-section. And if the baby came out with low APGAR scores, I'm like, it was a sick baby. It's a good thing I did a C-section. So it was pretty good to be me. I was always right. And it blew my mind that, that those things wouldn't make sense. So I had to get to the bottom of it. And then when I got to the bottom of it, it looked like, it was driving maternal mortality. And then when I was trying to understand that, it was like, well, racism is driving and I guess it's like not being able to tolerate BS also. And just really needing to like say it how it is. I was struck by the comment that you made about innovation sometimes being a press mill. And I think a big part of what's driven every step of my career, including this current one, is to sift through all that and figure out like what's real here.
Yeah, the signal to noise ratio there, it's getting harder and harder.
It really is, yeah.
And you touched, twice now, and we hear it in every couple statements. First of all, this is a testament, this group, that you could negotiate, be fierce with each other, challenge each other for a decade plus, and still sit down together, right, for patients and consumers. And this is evidence today, because there wasn't one person up here that didn't immediately answer the call and love to sit down with us today. So just remember that if you ever feel like you can't walk in a room and be fierce on behalf of your organization or patients. The diversity, equity, and inclusion front, right? Neil touched on it, a couple of you touched on it. Technology levels a playing field. Graham, I know you're incredibly passionate about this. Everybody is. I know it's a part of my voyage with access and how Kairos has been able to do that directly, indirectly. Let's hear from each of you, but kick off, Graham, on that and what you think about it.
Yeah.
Also personally, just being in the field and how you've thought about that and woven that into your strategy.
So, I alluded to this earlier. My parents raised me with this idea that there's a role for every one of us in the world, and I just found that an incredibly affirming worldview. And one of the foundational pillars for Kairos was the movie Moneyball, which some of you may know from the sport of baseball. And I'm actually just realizing I'm going to be very careful with this analogy as a Boston Red Sox fan in New York right now. But what baseball figured out a generation ago was that there weren't inherently good or bad ball players. There just were people who were better in certain kind of situations, and that you could use information to understand that this person might be better playing this position or going up against a left-handed pitcher in night games. And by using a data-driven approach to understanding all these relative competencies, you could put people in situations where they were playing to their strengths, and the team would therefore benefit by everybody's gifts together. And having practiced in healthcare with, again, some of the folks up in Boston, I became convinced that we were a lot like baseball players as well. We might stink at doing hip operations. We might not be the right person for this, but we all had a place and a role to play in here. And if we could increasingly use all the information that was available in healthcare, we could understand and display all those competencies and allow people to make that right match. And so, to me, access actually starts with the publication of that information. So what we do in our technology, we aggregate all these data points about each provider. So usually about 150 or so data points: name, rank, serial number, their picture, their web bio, the locations, the insurances. All of things matter at different times to different people to help them find the right provider. I might need to have someone that looks like me and speaks my language, or I might need to have someone who's available in a morning where I've got daycare coverage to find the right care. And so, to me, access starts with that, the ability to publish digitally who a person is, whether it's a badge that they're sensitive and open to certain communities, or just a personal statement that allows them to express how they think about healthcare. I'm a runner, and so I'm not going to immediately say you can't run anymore, right, if you're coming to me for an orthopedic injury. We try to enrich that experience a little bit with some of our work. So we have a clinical library that we've developed over the last several years that allows someone to describe what they're looking for. So you mentioned rheumatologist. I'll tell you in our search log, some providers don't know how to spell rheumatologist as well. And so you can search for the sugars in the Southeast, and we know we need to get you to a diabetologist. And that, again, begins to kind of break down and allow people to access healthcare wherever they start their journey. So I think that's the first way that we think about it. The second is what you alluded to with the technology itself. And boy, digital really does begin to level the playing field. We see very different searches of what people search for online versus what they ask a call center agent in the Midwest to do, right? And so whether it's mental health, whether it's gender reassignment surgery, the ability, the safety of being able to explore things online really begins to allow people to take the time and navigate there. So that's been wonderful to see. Our work is not done. We actually have a wonderful partnership we just kicked off with Perkins School of Mind up in Boston to begin to understand how people with different learning abilities, disabilities are coming to and accessing digital as well. Turns out light gray font on orange, not a great banner to have, right, in your health system. And so how do we begin to think about that, positioning things on the screen, making things available for a robot that can read the screen if you're not able to read as well. And so, again, I think we all have a role of making sure that our technologies are inviting and are inclusive to folks trying to get in.
When we think about type 2 diabetes, when we think about technology and getting access to big populations, what are you seeing in that field, and what are you guys doing about it?
Yeah, I appreciate the question. I'll build on what Graham was just saying, because this is a major issue when it comes to health equity. Over the last year, there's a lot of talk about COVID, clearly, and people saying that diseases don't discriminate, but clearly they do when you look at the data, and that is really true in type 2 diabetes. So 40% of the COVID deaths were type 2 diabetics, which is far more than the percentage of diabetics in the population. When you look at who are the diabetics, eventually, unfortunately, it's going to be a majority of the population. But right now, among Medicare beneficiaries, 30% of Medicare beneficiaries over the age of 68 who are white have type 2 diabetes. For the Hispanic community and for the Black community, that's 50%. So the disease burden is not equally shared. And so what we're working on is, number one, an individualized treatment that takes into account people's circumstances, the foods they eat, the treatment they have access to, and making sure that the care plan is relevant for them. We're not dropping a clinic into the Upper East Side serving a population that's right there. We're using continuous remote monitoring, telehealth, to be able to serve people anywhere, and then customizing and tailoring that care and the coaching to the individual's specific circumstances so that we can start to reverse some of those inequalities that exist in the population. There are obviously a whole bunch of reasons, social determinants of health that people like to talk about that are impacting that, but the disease burden is not evenly shared. The outcomes are evenly received. So for us, we think that's one of the biggest ways we can make a difference here.
It's great. So amazing. I think we don't often think about how technology, the data, and the use of it fits in with giving us more information around diversity, equity, and inclusion.
Lenny, can I quickly add
Yeah,
to
sure.
this? So, I think that the existential issue for the healthcare system right now, for the public health institutions in our country, is trustworthiness. And it's not, the job of the people we serve to be more trusting. It's like our job as the industry to be more trustworthy. And when we think about what that requires, we have to produce more equitable outcomes, but the way that we do it really, really matters. And I just sort of hear that as a cross-cutting theme. Like, you have to be reliable and show up for people, and you have to affirm them along the way. And, I think right now the industry is in a little bit of we shouldn't be using DEI as a checkbox or even necessarily as a phrase, right? Like, fundamentally what this is an opportunity to use digital technology in particular to change who's centered in the healthcare system. And I'm struck by the way that by removing geography as a constraint, you can make sure that you're matching someone with the technical expertise that they need, which we've talked about, but also someone who shares their lived experience. And in my world, in maternal health, that can be life-saving. There's data that shows that if you are Black in our country and you're seeing a Black provider, that can make a really big difference in your outcomes, because the reason that maternal mortality is 3 to 4 times higher is that some people are less likely to be seen and heard in the system and believed when they have concerns. So I think that's both the challenge and the opportunity that we have.
We've always talked about, debated, and observed just a lack of innovation and a lack of technology driving women's health. Number one. So there's a why part there. And then hit us with facts, because I was floored by some of the reality and the facts of what's really going on in the United States and America.
Yeah, no, let's talk about being in Manhattan today. 1 in 3, look to your left, look to your right. Someone's had a C-section, right? 1 in 3 people get major abdominal surgery to give birth, and 1 in 10 of their babies goes to the NICU. That we've increased the amount that we're operating on people to give birth by 500% in the last decade, and this is meant to be a rescue to save people. And yet an American today is 50% more likely to die than her own mom, 3 to 4 times more likely if she's black. And term infants, as a result of all that stuff that we're doing to people, are no better off. So that's a pretty damning set of statistics, and that's just sort of the case in fact. I think the why, there's something about the fact that we're all born that I think makes us somehow less empathetic. You know, like when I worked in politics and there was a meeting on breast cancer, you could push a button and like thousands of pink ribbons would show up. But for maternal health, I don't know, there's this expectation that moms have to put their own well-being last to put their families first. And so you have like Moms Against Drunk Driving and Moms Against Guns, but there's not like a Moms for Moms. There's not like a lobby. When Kate Ryder, our CEO at Maven, started her company, talk about relentlessness, she was told that the total addressable market wasn't big enough for half the population. Here's a statistic. 25% of all hospitalizations are a mom or a baby after a birth. That's so many that it's 0.6% of our GDP. And if you were to take our whole economy and spread it across the table, you could see the cost of hospitalizing people to give birth with your naked eye.
Rob, tell us about Zimmer Biomet and the orthopedic device space, and just even what you guys pulled off. And you talked about it briefly, but first sensor implanted in a knee, in a human being in the world last Monday.
Yeah. Around what I had said earlier, right, that our belief that data will eventually change outcomes in orthopedics. So for us, it's around AI. We believe very strongly in it. And the fact that we'll have this ability to data collect across this care continuum. So I'll get to the smart implant in a second, but our ability now through digital tools, through care management platform, we call it My Mobility with Apple Watch, this ability for providers to push content to patients pre- and post-operatively to allow them to prepare for their surgery, recover from their surgery in the comfort of their own home. Apple Watch, if there is a wearable included, also allows for data collection, right? For this ability to start to get a movement signature preoperatively. How are they moving preoperatively? How much are they moving? With iOS 12, Apple had an update around gait quality, so we can now get things like double limb support time, speed ascending and descending stairs, stride length. All of that comes from their mobile device, which many patients have. And then intraoperatively with the robot, having this ability to data collect intraoperatively from the robot. Things like initial knee state, the final knee state, the laxity profiles, how that knee is balanced. We can all get that from the robot. We can tie that with data that we collected preoperatively. And then postoperatively, as Lenny said, we just did our first case this past Monday here in New York City. It's a product we call Persona IQ. It's a smart implant, has sensors built into the tibial component of the implant. So now the surgeon has this ability to collect data directly from the implant, this high fidelity data that they'll be able to collect longer term. They can collect it for up to 10 years and tie that to outcomes. So now we can start to develop a pattern on what are the decisions made intraoperatively and how do they relate directly to outcomes. To eventually get to a predictive state. We just had an abstract that was published recently around that prediction, where the surgeon found that if the patient had less than 1 millimeter of medial laxity and flexion, they had a significant less step count at 6 weeks. And that may seem obvious for the orthopedic surgeons in the room, but the fact is that we're now able to make this correlation, right? That used to be the black box of the surgeon's mind. This is how I balance a knee. I sort of wiggle it. I think it's a fantastically balanced knee. But the truth is, sometimes they just don't know. There's something going on that they just can't figure out. And I think, again, for us, it's data. Data will eventually lead to those insights that have been really, really stubborn in the industry. It's been sort of an intractable problem in orthopedics for some period of time. So we're really proud of that first implant in the knee.
How does one charge a implantable device that's going to give you 10 years worth of data?
Through a battery. The battery stays in, right? And it's you don't recharge the battery, Lenny. It stays in there and it samples throughout the day. So it's programmed to sample throughout the day, but it's a great question.
Such a great time to see that technology become reality. I'm talking about the battery, not the anyways, no. Yeah, that's great. So you've all gotten a mood for this panel. I mean, the one thing that I want to hear from them also is when these challenges have come, what are the things we've done right in the provider environment, the hospital environment, in the ecosystem? Tell us where we've challenged you, where maybe the company was wrong, or it helped iterate, and move the technology forward.
The hardest thing is when you're going in and trying to sell into an organization and you get a polite no or a polite maybe, and you don't really understand why we wouldn't work in your organization. So in many cases it has to do with plugging into your existing infrastructure and how do we fit into the workflow of the physician, because as much as we believe in our future and we're trying to move people towards it, we're not going to fundamentally change the practice of care in the entire hospital. So we need to figure out what is that balance between moving towards the future and plugging in. And in many cases, we came back 2 and 3 years on with changes to the product that fit some of those needs. Maybe not the exact ones you asked for, because every customer wants to be a product manager, and that's a dangerous road to go down. But underneath that was valuable feedback for us that made us change the product.
Selling to payers and providers is a daunting task. When we first started, we had this phrase, don't poke the dragon. And what it meant was we were going to try to sneak around the CIO's door. And at the 11th hour, you get one of these, and you get caught. But you were trying to be efficient, right? You were trying to go in through a champion that got you and not have to have 100 conversations. We realized, and I think it's probably true for everybody up here, that your solution inherently does touch everything. So we are wired into some of the core people and EMRs and scheduling systems in the organization. We're powering a website the chief marketing officer cares about. We're powering a call center that the operations or access officer cares about. We've got deep clinical engagement and things. The CFO is writing the check. You have to engage all the different stakeholders. And I think so we flipped it and we did a whole 180 and took on a campaign where we were actually, and sometimes years ago, convening different parts of the organization for the first time that hadn't really talked to each other and hadn't really thought holistically about patient access and how you were going to navigate patients through all these different channels in. And that was very, very important for us, was to systematically think about all the different stakeholders and how we were serving all of them to deliver the right product. It took a while, but it was the right thing to do.
That's great, and you've all been successful in doing it, which is amazing. JL, same question. And what advice do you have, and what advice did you take that helped you change your product and move it in a different direction?
So I've seen this both from my perspective as an entrepreneur and also working with you, Lenny, riding shotgun with you for a number of years. As Kevin was suggesting, you have a lot of people within the hospital environment who want to be product managers, right? They've been very successful, to climb to the heights of a Sinai or an NYP or an HSS, you have to be really smart. And what happens is people are often very confident in their ability, and they'll say, hey, listen, I'm an orthopedic surgeon. I was very successful in my career. Obviously, I can build the next Facebook or I can build the next Google. Often I remember working with Lenny, and I've seen this again at every major academic center where I've consulted. Somebody says, I have an idea for an innovation that I want to be like Facebook or like Google. And what people don't understand is, like, the Facebook that you see is a 15-year-old company that has raised billions of dollars and has invested billions of dollars in retained earnings to see the product that you see. Google is an even older company, right? Google is like 23 years old. So again, I think the key battle I always found myself fighting when I was riding shotgun with Lenny, and actually this was my job to be the guy at the table to try to reveal this truth, is you cannot build Facebook or Google if you're a doctor at a major academic center. What you need to do is try to find a partner who has already started to develop something like that and give them the opportunity to grow with you and build something that you're going to need and something that you're going to use. But if your assumption is that right out of the gate, in 3 months I'm going to have a Google for orthopedic surgery or a Google for rheumatology or whatever, you're going to fail. And again, I've seen that so many times in so many places, and I'd say that's the number one bit of advice that I would give to anyone having sat on both sides of the table.
And where do we challenge you, where you might have been wrong or the company might have been wrong, and or where do we change the outcome of something?
No, I think the key point that large organizations make is that, again, you can't fake it till you make it. You can't, a very common concept, this was actually pioneered by Facebook, is break things as you go along and, you fix them as they break. The problem is in healthcare, as Graham was suggesting, if you break something, somebody dies of an avoidable issue that they didn't have to die from, right? We can't do A/B testing on treating people and not treating people. So again, I think the key thing is helping people who may not be steeped in healthcare, who may not understand what the pressures are in healthcare, that you have to be cautious, you have to be careful, and we want to innovate, but we have to do it in the way that is acceptable to our mission.
100%.
But what we take away from that provider relationship that has helped us is, I'll state sort of an obvious answer, and that is you have to solve problems, right? I think sometimes as an entrepreneur or even as a product team, you can sit back and think of just the sexiest things you can do with your tool, right? You're creating digital assets, and they're just going to be incredible. But they don't solve problems. They have to solve efficiency problems. They have to reduce costs. They have to improve outcomes. You have to demonstrate how they improve outcomes. And providers push you on that, right? And they push you on, for digital tools in particular, I think there's been an expectation, a good expectation, that our digital tools become more consumer grade. They can't be medical grade. I think somebody made a reference, and Graham, to Epic earlier. That it's a necessary tool. It's not always friendly to use from a provider perspective. But I think when you're delivering digital tools to both patients and providers today, they have to be consumer grade. They have to be intuitive and easy to use. If you are talking about an ecosystem, it better be a connected ecosystem, and it better be easy to access. Give me single sign-on. It can't be clunky. And I think and providers will tell you that. They will push back vehemently against that.
One of the most critical aspects of a healthcare organization's executives when thinking about technology is where to buy and where to build. And I'll make a ridiculous joke, but there's versions of this that happen in digital health, which is, hey, we need ambulances to bring people to our hospital. We need to build ambulances, right? Now, you shouldn't build ambulances, but in tech, it seems like you probably could build a lot of tech stuff. And so what the other way you sometimes hear this is, oh, every healthcare system thinks they're different. And they are, but there are also some commonalities. And I think as we as technologists advance, and there actually are more commodity things off the shelf, you shouldn't build a provider directory. I know that's self-serving, but we do this. But you might want to have us do that so that you can then create a wonderful mobile experience that's really custom to your organization and spend your calories there. And I think that's, as we advance as technologists, trying to keep up with what's commodity, where are the really best of breeds, and then what can I then focus my time spending on really differentiated stuff that touches patients and is unique to ours. That's the ongoing conversation, I think, to have.
Coming out of something else that Graham said, I think there's a dichotomous choice between when to make an end run around the CIO and when to tell somebody that their baby is ugly, which as an obstetrician, I know better than. But I think as, an entrepreneur who's always not satisfied with the status quo, I think there's those really key choices where, especially in digital and tech, you can move really fast and just build your own ambulances or whatever if you don't like the way the ambulances are, but it's not always the right call.
Second to the question I asked Rob about how you charge the implantable, I think everyone else, including myself, for a long time, except for the last 5 years, wasn't afforded the opportunity to understand how you guys make money, how the companies do. So there isn't a not-for-profit, other than myself represented up here, these are for-profit companies, publicly traded companies, early-stage, large companies who have raised a ton of money. You've heard from everyone. You know that they're passionate. You know that the patient and the consumer drives them. That aside, your companies have to stay afloat. And I think, again, on the administrative side, on the larger conversation side, nobody talks about, and it's okay to create value and drive economics, right? And then drive those economics to continue to scale that value.
we tend to shy away from it, don't want to understand about it. So tell us, how do your companies make money?
The biggest frame shift for me in the last 3 months is moving from a space where my value to the world was to be financially disinterested, right, and to be neutral and objective. Like the CDC would put out new data, and I would get to have a non-dumb take because I'm objective. And now, capital is part of the supply chain, so it's a little bit different. And just to personalize this a little bit, I think part of what compelled me to do this actually is that there's probably many pathways to profitability or revenue, but certainly in a lot of the health tech space right now, there seems to be a pathway where you're like direct consumer, and if you do really well at that, you can sort of level up to the next level of scale, and then you become like an employer benefit. And if you're really, really good at that, you can like level up and do the next thing. And for me, Maven is at a place where it's like crushing the employer benefits thing. And again, like the most vulnerable person in America right now is probably a pregnant woman of color in the Mississippi Delta. And to really help that person, you have to be able to not be B2B, but B2B2C. And so it was an opportunity to build a product and a business on top of this chassis that it was working for a different segment of the population.
To me, it's all part of the ecosystem, first of all. I see the ability to align profit with public health as a way of driving sustainability, right? So if I can make money, I know I'm going to be here and to serve folks. So then it's really a question of how do you align your own business model with those of the organization that you're serving. And so we charge, either per provider or per member basis. And so the idea is the more we're helping you across numbers of providers or through different channels, the call center, the website, the referring provider app, the more we're going to share in that ability to kind of drive efficiency. You've got to be able to back it up, right? And so, we're spend a lot of time talking about the ROI of reducing leakage out of networks. We find many organizations across the health system world, they're sitting with 20 to 30% of their appointments empty every day, right? Not evenly distributed. Dr. Famous is 100% booked and out for 17 weeks. But the brand new doctor who does exactly the same thing as Dr. Famous, she's sitting empty because no one knew she existed. And that little mailer card you sent out that Dr. J. Raja joined the practice got thrown in the trash and everyone kept sending to their buddy. And so the ability to kind of unlock that capacity and steer people in, if you can take some of these organizations and fill schedules by 2 to 10% more, that's hundreds of millions of dollars of value you're driving back into the organization. So there are real win-wins here that I think that we shouldn't be embarrassed about.
No, not at all.
I'll build on Graham's. Virta for me was unique among the companies I've joined because many of the healthcare companies I've been in before either charged a subscription fee or a per member per month for a whole population. We're paid when our program succeeds. So we're paid for enrolled members who succeed in lowering their A1C, lowering their body weight, and getting off their meds. And it works because the reduction in meds pays for our service. So we end up saving, Milliman validated the methodology we use. We save about $10,000 in cost, in hard medical cost over 2 years for patients who are in the program, and we charge about half of that.
So, insurance doesn't cover a lot of what we do, which is, I think, again, one of the horrible aspects of addiction care is that there's a very rigid model for delivering addiction services that is heavily biased toward inpatient care, residential care for 30-day periods. So again, what we're doing from an innovation standpoint is moving a lot of those resources to an outpatient basis and providing a much broader range of providers in somebody's addiction care. So again, as I said, insurance doesn't cover much what we do, except for the doctor services. So we work directly with families and individuals who pay us directly. And going back to what I was saying before, in terms of innovation, I think one of our innovations is that we've made it very simple for people to work with us. They pay us one fee at the beginning of every month. That fee covers whatever it takes to help them achieve their goals, right? So if you want to see the doctor 10 times, we'll do that, right? If you want to get on a Zoom call, we'll do that. If you want to email us, we'll do that, right? Whatever it takes. And I always tend to think about sort of like care being like a matrix, right, with multiple dimensions where, some people are in different parts of the matrix in terms of what they want as their service. So again, we charge a subscription fee. It's month to month. It's very simple. And if the patient is doing well, if our client is doing well, they will renew for the month. So I always tell the folks on our team, we provide the ultimate value-based care, right? If our client sees that what we're doing is valuable, it helps them achieve their goals, then they will renew. And that's the way we make it.
I think for us, right, at Zimmer Biomet, it's no secret that we're a traditional med tech company that sells implants. So the provider buys the implant, surgeon implants that implant. And then on the technology side, we have probably a little longer runway, right, to revenue recognition, because we're an implant company that sells implants. But at some point, the shareholders will look at our business and demand a return, and I think that we'll look to value creation. We have to prove our mission, and that is around all the things I talked about earlier, that we will drive value in the system through lower costs, through, yes, less resource utilization, through the digital care assets, and then through the data tools, eventually creating insights that lead to better outcomes. We think that, right, that will be value creation, and at some point, everything will be able to be capitalized on.
Yeah, I think, Lenny, Rob showcases one of the really interesting dilemmas for all of us, which is how do you price the first ever of something?
Yeah.
And I think one of the real values, as I reflect on it, Lenny, of getting champions in an organization where you can have real partnership conversations was that. Like, how much should I charge for Kairos? How much does this mean to you? And we're not going to extract as much money as we can. Let's figure out a way of doing that fair. That is a really, really important role you play in helping us get to market. Yeah.
In a related story, Graham, we left one large health system really excited the day we had closed the deal, and the CEO turned to us and said, "You way underpriced this."
Yeah, good stuff. So I know we've been a great discussion today, and we could probably go on for hours with this crew. We want to take questions from the audience.
My question is, it's kind of since we have a bunch of MDs on the panel as well. It's when I was growing up in the UK, I didn't know that I wanted Google Maps in Wales. I just thought, let's look at a map. I didn't know that I wanted fabulous panels on networks. I have when we think about healthcare innovation and automation, in my area is health systems, how do you engage our patients and providers? Is it that they don't know what they want, or is it that they don't know it's possible? So how do we create those partnerships that actually succeed as opposed to going around the CIO, going around the CMO, or that kind of stuff? Yes, the question is how do we get not just the providers, but also the patients that they can see beyond,
The reason it strikes me is because in the sharp focus on maternal mortality in our country, we have sort of forgotten that people expect and deserve and want more than emerging from childbirth unscathed. It's a pretty low bar. And so, like, very much to your point, a big part of the value creation opportunity, and even the story that we need to tell when we think about pricing and the value that we're providing, it's not necessarily always like the hard clinical outcome, right? We're reducing C-section rates, but if we're affirming people, if we're making them, the unlock for all of healthcare, there's like a 2x2 table in my head of people who are high risk and low risk of something bad happening to them in the healthcare system. And then there's like people who are like relatively like unengaged and people that are more engaged. And if you can take low engaged, high risk people and activate them, like you've unlocked all of healthcare, right? Then you're like really managing care. And to do that, you have to do exactly what you just said, which is tell them what they really deserve and then affirm them along the way.
One of the things that we actually found effective, at the end of the day, we're just storytellers, was actually demos. That if you actually could bring a car in and say, this is what I'm talking about. Now, the first few demos, you'd still get questions of where does the hay go? And that's part of trying to describe a possible vision of where to go. But that was really, really useful to, again, align. People could start to think about the car, think about how they could get to market faster, to bend the analogy. And that ended up being a very productive way of doing that.
I do a lot of work on patient engagement and cultural competence, and I often, not sure the role of technology, and does technology actually help or does it actually hurt? Because from my perspective, health disparity, particularly for African Americans, it's about like decreased human value. So if I didn't value you when you were in person, am I going to value you through telehealth? And I think one of the things that we need to address, and is what I realized, the perception versus reality. So there's a lot of buzzwords now. So we started with health disparity, so now it's a nicer word, health equity. And then we started with non-compliance, and so now it's non-adherent. And so now we have social determinants of health. And I think the problem is when you box black population into the social determinants of health, you're leaving out 60% of the population that's experiencing health disparity. Because when you look at COVID, there's a perception reality issue. COVID, Prince George County outside of D.C. is a very affluent black population, and they have a highest COVID death rate in that area. Brooklyn, New York, 3 public hospitals, a state hospital, about 7 or 8 private hospitals. The public transportation runs throughout black and white Brooklyn, but however, the black population in Brooklyn have the highest death rate. People that work on the subway, back in 2020, I remember hearing that it was, at that point, 60 individuals had passed from COVID. 50 of them were black. They have union plans. They have health coverage. They have pensions. So when we box it into this now social determinants of health, it makes me a little bit not happy with that, because you know what? To me, it sounds like it takes the health system away from the responsibility of delivering care to human beings across all races. And I think we need to look at it from that perspective. And there are technology that can be done to improve health equity, but it has to be done on the patient basis, patient engagement. Everybody talks about patient experience, that we jump to that without the engagement. If you don't engage me because of whether you have conscious or unconscious bias, my health is going to go south. JAMA had an article in 2019, and I was blown away, and I'm sorry I'm taking too much time, but it was blown away, and the question was, is physician burnout due to black patients? Okay, I would be happy to share that. And but at the end of the day, when I read it, I was happy that they put it out there so that we could have this conversation. But once the interns, when they started out, by the time they got to 30-year residents, their biases were decreased. But the impact on health outcomes, if that's the perception. Thank you.
Thank you. I mean, look, I think in the United States, I think few of us understand like how unique our experiment here is in the United States, right? How do you take people who are so different, who come from so many different places, have so many different backgrounds, live together, right? And, live together without, open war every day. I mean, I think, the United States is a special place. But that said, we often live in silos and are often not familiar with the experience of people who may be different from us. So I think that organizations that do really well, let's say in terms of, helping whatever population you want to address, do so by going out actively to find out and learn about the experiences of those populations and then build that into the technology. So again, I think a big problem that you have in Silicon Valley, and I'll say this, and I'll be provocative in saying this, a lot of tech is being built by upper middle class white kids who went to Stanford, right? And if you're an upper middle class white kid who went to Stanford, you probably don't know the lives of lots of different types of populations. You may not be familiar with the Native American population. You may not be familiar with the Latino community. You may not be familiar with the black community. And there are things that you have in your head, models that you have in your head that are reflected in the technology, right? And the example that I always like to give when I talk about sort of my mind being blown from an experience, when I was a third-year medical student, we had a rotation unit where we did home visits to see patients, okay? And I remember going to a home in Washington Heights where there were 3 sisters living together. They were 95, 94, and 93. And the 3 sisters had not been out of their apartment for 5 years, okay? They had not physically left their apartment for 5 years. And everything that they experienced was things that were brought to them. And it had never even occurred to me that people live like this. And there are many people who are homebound. And as a result, that sort of changed my view when I was seeing patients in my clinic who were 80 years old, who were schlepping it out from the Bronx or Upper Manhattan or whatever, to say, okay, I had never thought that these people were living this experience, and I need to adjust the way I think about helping to order their meds or helping to order their transportation. And I think that's just a broader model, right? We just have to think about all the diversity out there and really ask a lot of questions questions, and don't assume that just because like you're a smart person, you know how everybody else lives.
It's exactly right, JL. And we've, Moneyball runs pretty deep at Kairos. And the reason we care about it from a cultural perspective as well is that we don't believe we can build the right tools for people unless we look like the rest of the country. And so we're not there. But every month we publish our stats in front of the organization. We have employed a lot of different things to source from different places because we need to look like everybody else to do that. And it's not something that the CEO and the executive team or the board owns. It's every single person is responsible for creating the community internally that's building the tools to serve the community externally. I totally agree with you.
Hello, my name is Alex Wong. I'm a health system specialist working for the Bronx VA, working the VA system. I think like other health systems, during the COVID-19 pandemic, we have really pumped up our efforts in telehealth or technology health in terms of delivering the care. So my question to the panel is, with the aging population in the U.S. or some other regions, how do we bridge the gap between like patients being not able to utilize the technology in order to capitalize on the delivery of the care? So like patients being older, or patients have no experience with computer or internet. So how do you bridge the gap in all kinds of technology?
60% of our searches are on mobile devices, and so you've got to be mobile optimized. You have to be in Spanish, and I will scold some health systems here. I'm disappointed by the number of organizations that pick us up on our Spanish-speaking directory and find a doc. You should be providing that to meet members of your community. So yeah, it's just different ways of trying to accommodate everybody where they're coming from.
And I think Graham touched on it earlier, but just from my point of view, optionality is important, right? So while this is a digital, an innovation technology discussion, being able to create options for many different ways people engage with an organization and a provider and to access differently, they should have the option for phone, have the option for a conversation, have the option for text. I think that's the right answer from an access standpoint. And I know, you're touching on Kairos earlier, but that's one of the ideas that you have around, all of those thousands of variables that make access important. But we can't fall away from that. I know what you're saying, like, we immediately reacted and went to digital, and now when the tide comes back, how do we address those who may not be digitally proficient? And that's the answer. The answer is making sure that we don't just do that, and we create options for everyone to access.
And to build on that, my mother is 83 years old. My sister and I consistently try to get my mother an iPhone. We try to explain to her that it's easier to use than the flip phone that she has. My mother will never be on an iPhone, ever. She doesn't really use her flip phone well. So, we have to give her resources so that she can make doctor's appointments. The telephone is a technology, right? There's IVR. There's lots of technology built into the telephone. The telephone was revolutionary when it was invented. So I think we just need to realize that some people like my mom they're never gonna have a device. You're never gonna be able to put a device in the house that's not gonna collect dust, right? Yeah. But that phone that she has that's connected to the wall, she's talking to my aunt, she's talking to my uncle, she's talking to us all day long. That's her technology. So let's figure out how to let her do what she normally does with that magical technology that she has on the wall.
Absolutely.
And I think big tech has a role to play here as well, right? I think nobody's represented from big tech up here, but I think initially when we launched our content, it was on mobile only, and then we moved to web as well because we knew that some patients didn't have mobile devices. But they do have aspirations of disrupting because they use that word, right? And we talked about how probably not the right word to use in healthcare, but they do have aspirations of disruption in healthcare. So I think they do have some aspirations on this front and maybe even some responsibility around this.
I think I would reframe it a little bit. It's not only through the lens of age that people have difficulty accessing these technologies, and there's not a lot of over 65ers having babies. That's not really like my population, but I do have to think a lot about how to engage people digitally who may not be. And at this moment, what I see is the brick and mortar healthcare system doing what it's traditionally done. And when you talk about maternal mortality, the minority of it happens in the hospital. The overwhelming majority, to address it, we have to be able to meet people where they are in their communities. And so I also see a lot of momentum towards community-based organizations and community health workers, which, yeah, I mean, I think that makes a lot of sense. We need to be able to meet people where they are that way. And also, but even for them, they can't be there all the time. And there's an opportunity to fill in that interstitial space where you can connect with somebody at the moment that you need it. I think that's a real game changer. So one of the things that we've been thinking about is, can those community health workers facilitate some of that digital engagement? And what is our responsibility in trying to help bring people along, or not even bringing them along, but bringing them into the benefits of these technologies rather than simply looking at it through like a tech literacy lens. Kind of like the geeks at the Apple Store. It'd be great if community health workers could work that way.
First of all, congratulations to all of you guys on getting to where you are in the startup journey. I know how hard that is, and you're all to be commended. I had a question. JL was talking about the sort of startup ethos around innovation, and specifically the old Facebook move fast and break things that was mentioned. And we've all seen the challenges that our health systems have had with cybersecurity over the years. How do you all view your role in balancing innovation with the challenges of cybersecurity, especially early on in that startup journey when you have no resources and everybody's just struggling to get a product built?
I think you can't get it wrong, right? I mean, this is an area where you can't just break things. With PHI, you must get that right. It's absolutely critical. As a matter of fact, you just won't deal with health systems if you can't prove that you have the credentials around cybersecurity and you're taking the right precautions with PHI. So I just think that's an area where if you're a startup, you have to have funding for security.
Yeah, I'd agree with Rob here. The two kind of never events are, number one, a patient safety issue, and number two is a data security issue. So if you're inside our organization, you see that those two areas have been very well funded and we're extraordinarily cautious. And the move fast and break things is not touching those areas. And even Facebook has moved away from the move fast and break things mantra as they've grown. Obviously this week, not
No, it's one of the taxes, of getting into healthcare IT. You have to be SOC 2 compliant and and high trust and all the rest of it. But it's obviously there for a reason. I think what's getting tougher for all of us is that you grow as a company and initially you want to do everything. You're going to cure cancer and be CRM and digital health and front doors and all the rest of it. And then you begin to realize we're a scheduling company. Right? This is where we fit into the ecosystem. We are now integrated with dozens of other companies. And look, we can't go down. Like, we go down and people start getting scheduled at large organizations. And so we are now codependent on so many other people in the ecosystem that it is no longer just about building security into your own tech. It's about all the partnerships and relationships as well. So this is not going away as an issue, and I think it will just continue to be a bar that we all have to get over to serve health systems.
David, I'm a health systems specialist at the VA. Much of the discussion today has been implementing tech targeted towards saving money and driving efficiency at the provider's expense. However, there are many older technologies to help connect patients to providers with shared experiences. I'm thinking specifically of virtual group prenatal care. However, they don't have a high utilization because MCOs and insurance companies haven't been thoroughly convinced of their value. Are any of your companies targeting their efforts towards convincing insurance companies and to connect the two industries together?
So I can comment on that. So as I said, insurance does not cover many of the services that we offer, even though a recovery coach working with somebody with addiction can keep that person out of a residential stay that's going to cost $50,000, huge expense for the insurance company, huge expense for the individual. So we do spend a lot of time talking to United and Aetna, and we're moving in that direction, but it's very difficult, right? An insurance company is insurance companies are literally the largest entities that exist in healthcare, right? United has 50 million members. Aetna probably has something close to that. So, those are large organizations. It is very difficult to get a large organization that's like a 1,000-car train that's moving in this direction.
With 1,000 CMOs.
With 1,000 CMOs, right? Different operations in every state that they're operating in. It's very difficult to make that change. So, as Neil was suggesting, The strategy in this space is to develop traction in your direct-to-consumer space, get people saying, hey, this is actually a valuable service, it's saving me money, it's creating value for me, and as a result, can I get this covered as an insurance benefit, or can I get my employer to cover this? So that's really the best practice strategy right now. But it's not easy to change, the operations of a major insurance company.
And also, I mean, I think the how do you price something that doesn't exist yet thing, it's a challenge and it's like a tremendous opportunity. Because I mean, on many of these cases, like you get to be the educator. This is like where, maybe being a professor comes in handy in sales or something, but like they don't know anything about prenatal care. And you're like, well, the model of prenatal care in America is 100 years old. It's not based on anything. It's not been updated in 14 visits in 9 months. It's a lot. That's like talk about schlepping, right? And then you're like, well, in the last year and a half, all of a sudden we took a century-old model and we scrambled it, and now there's 1,000 natural experiments across the country. Don't you want to know it works? And like you have that opportunity. I mean, we are storytellers at the end of the day, but I think there's an opportunity in the fact that it doesn't exist yet at the same time as it is a challenge.
So we are reimbursed by insurance companies and covered by employers as well, and it comes down to the data and the burden of proof for an insurance company's actuaries if you're going to come in and claim cost savings, especially given the number of overlapping programs they have, is very, very high. So for us, we started with the simplest, which is if this type 2 diabetic was on meds before they were on Virta, and now they're on Virta and they've been able to come off their meds, it's a very easy value for us to claim. There's a number of other things we're collecting data on over time, but we'll need 2, 3, 4 years of data before we can go and claim that the community aspect that's built into our experience is reducing costs, and we'll have to be able to point to the specific costs that it's reducing.
And one quick anecdote. So I'm an advisor for a company called Cecilia Health. They used to be Fit for D. They're certified diabetes educators. They're moving to being an online diabetes clinic. I remember, call it 3 years ago, they wanted to work with a small insurer in a mid-Atlantic state, right? So just imagine, a number 5 or 6 market share player in a state that's got less than 8 million people, right? So a small insurance company. The first meeting that we had with them, call it the second meeting, because really the first meeting was getting this second meeting. There were 8 different people from that insurance company at this meeting. There was like the head of nursing, the head of, the CMO, the assistant CMO. I mean, there are 8 different people just to have this initial discussion. So again, getting at the complexity, that's one small insurer in one relatively small state, much less a 50-state insurer. So it's very difficult, and it takes time. And I think the reason that you're covered is because you have the DPP program, right? So DPP is already recognized by CMS. So if you're already recognized by CMS, then commercial insurers will cover it. But if you're creating something new, it takes a while.
Yeah. So as a person who's so far survived being a Red Sox fan in a room full of 200 New Yorkers, we are trying to bring the payer and the provider industry together at Kairos. And these are two sides of the industry that have historically been at loggerheads every few years when they renegotiate contracts. But we approach everything with this win-win-win. So when we started Kairos, serving health systems and trying to bring patients, we were convinced that we could help get the patient to the right provider for them by allowing them to sort and navigate. We were then having the provider practice at the top of their license by, the brain surgeons doing brain surgery, not seeing headaches. And that we could do it in a way that helped the health system and their return on assets, if you will, really kind of filling up and routing to people and utilizing everything correctly. We're going into the payer space with the same philosophy, that at the end of the day, we can actually achieve a right, what's right from a clinical quality, cost effectiveness perspective, site of care across different conditions. And that, again, every organization, every provider in every organization still has a very important role to play, but by bringing this together, can we begin to bend cost curves, think about broadening the concept of right provider even more. So I'll let you know how it goes, but we're beginning to step into that right now.
Thank you. Thank you. Phil, I work in public health policy, but I wanted to come to a point that Neil made earlier about trustworthiness and how we leverage technology to build trustworthiness with our patients and our consumers, and what are the limitations of technology in that space. Certainly, Jean-Luc, Kevin, Neil, you work in spaces that are chronic disease and acutely aware, from my perspective, creating issues in our public health space and creating disparities across our communities. And do we have the opportunity to leverage technology, or are we still limited by technology to really bridge that gap in creating trust so that we can deliver the care that is available, even though people may not be ready to accept that care?
Trustworthiness is not just a virtue, it's an output of a system that's either working or not working, like fundamentally. And so there's like no widget or app that's going to save healthcare. It has to be sitting on a system that like makes sense, and there's no UI UX that's going to make things trustworthy. It's really a back-end problem. And I think the opportunity that we have with technology, it really is a scheduling, like everything's a scheduling problem. You know, if someone, I still see patients every Wednesday afternoon, and if there's a, you know, if they need to cancel because they're taking care of a sick child, which is a very common occurrence, or they live in Dorchester and it takes them a minute to get in on Boston transportation, and they have to reschedule, it takes weeks. Like, you know, whereas what we have the capability of doing theoretically right now, and actually in reality, is booking another appointment in 27 minutes. Same thing, like showing up when people need you. Like if you need a lactation consultant, you need them at like 3 a.m., right? And it makes all the difference in the world. If you're diabetic, the best way to address diabetes and pregnancy is not with insulin, it's with diet. And you're like, you know, change your whole diet on a dime. You know, like that's really, really hard, but it's totally different if you've got your phone and your refrigerator and you're planning out a meal at the moment you need it. So I think it's how we use technology more than anything else.
I agree with Neil here. It's about reliability and being there when the patient needs you. I'm not a diabetic. I'm on the borderline of prediabetes now, so I'm actually going through the Verta treatment to understand the lights of the patient's eyes. And I went traveling to Minnesota last week. First time I've been on a plane since COVID. First time I've been on a plane since I've been a Verta patient. 10 o'clock at night, I had questions about what I could and couldn't eat on the program, and I was able to text and get a response from the counselor and walk into a nearby grocery store and pick up a couple thing. If they hadn't been there for me in that moment, it would have been a very different patient experience and ultimately outcome.
My name's Steve Sally. I really appreciate the conversation around trustworthiness and some of the earlier comments around equity. And my question is around education. You know, one of the things that I've seen as EMRs have now, you know, taken over large hospital systems is that you see a lot of people, a lot of frontline nurses and techs who have great relationships with patients. They're leaving because the technology doesn't work for them. And so, in terms of the patients, you mentioned that, you know, the poor woman in the Mississippi Delta, the poor pregnant black woman in the Mississippi Delta, she also likely doesn't have access to technology. So how are we providing, companies like yours, providing education to people who work in healthcare who may not be comfortable with it, or to patients and families who don't have access to technology, where without that access, we're really increasing equity gaps over time?
So, you know, education is a huge part of addiction. You know, every time a family comes to us, I'd say, or 90% of the time a family comes to us, literally the first thing they say is, we don't know what to do. So, you know, what we've done is we've spent a lot of time and energy recording videos and providing written content that people can access on their phone, right? And, you know, or people can access on a computer if they can access one. I think these days, you know, probably 95% of people can at least access the internet via the phone or a computer that they have somewhere. It's probably more on their phone, actually. But I think, you know, you just have to make it easy for people to access education resources and make those education resources easy to consume.
What I'll add real quick is, you know, the woman in the Mississippi Delta, that's not like a random, on January 1st, like she's who I'm serving. And it's very, very different to have a Fortune 50 company market enrollment to engage people from Medicaid, where people might not even enroll in Medicaid until the third trimester. So, like, what I have to do is show up, like boots on the ground, and build relationships with federally qualified health centers and like answer that question. But I think, you know, one of the things that is very, very clear is that it's a tall order. And, you know, again, the opportunity that we have is to figure out who the most vulnerable person is and lean in and try to help them.
It's actually a great question to end on, because I think it's a challenge to all of us. I think to date, the pendulum has swung that technology probably is disintermediating a lot. I think a lot about the curbside consult. You know, I used to get a lot, hey, can you take a quick look at the EKG? Does she need to see you or not, right? That's hard to do.
It's
when
gone.
You schedule now an appointment 3 weeks out, and it's a challenge. I don't have a great answer. I think it's something we all have to be thinking about.
Thank you so much. Thanks to our panelists. Appreciate it.